So before Dr. Nguyen gets started with his lecture, I wanted to make an announcement and let you all know about something that's very exciting. For the past several months, Stephanie has been working with Vinny's group in an effort to try to obtain CMEs for our Friday weekly lecture series. And we finally were able to put in a process so that we will be able now to claim credits for these meetings. So if you go to the chat box, you'll see that I have posted a link. This link is a survey. So at the end of the lecture, if you want to claim CMEs, you have to go to this link and fill out the survey. It takes literally 90 seconds. It's a bunch of check boxes. In addition, for people who weren't able to join us but want to then go back and review it, when Stephanie sends out the weekly link of the lecture, it'll take you to a YouTube page, and at the bottom of the page will also be a link to basically this survey. So if you want to claim credits, you have to fill out this survey, and the survey will also be the mechanism by which we keep attendance as well. So today's lecture will be the first opportunity you have to actually claim CME credits for this. So with that said, I'm glad to see everybody's muted, and Ken, take it away.
Great. That's fantastic news, Peter. Thank you to you and Stephanie and everybody to get that achieved. I know it took a little while, but well worth it. But thank you. So I've got the opportunity to speak about current and future modalities in the treatment of superficial venous disease, what you need to know. So no disclosures. Just as an introduction, venous insufficiency is a really common condition, as we all know. As much as 40% of the adult population is affected, and obviously with many of them have varying degrees of effect on their quality of life. And so this has brought a significant amount of interest and innovation to the disease. You know, I did some search on just what type of papers have come out. Over I think 1,200 papers were introduced over the last 12 to 24 months just on venous disease. So there's a lot of research going on it. There's a lot of innovation. And clearly, there's tons of new innovation that's coming out, new techniques, and that's what we're going to talk about today. As we all know, optimal treatment of patients really requires multiple modalities. There's really no technique that's going to be perfect for every vein. And so it's important to use each modality and combine them in order to get the best optimal results. You also have to look at the patients from a holistic standpoint. You also have to kind of look at their expectations and give your best options for them. Historically, surgical intervention has been revolutionized by the development of these new techniques, and we're going to talk about some of the old techniques as well as some of the newer ones as well. So when we talk about treatment options, I think you have to talk about conservative measures, you have to talk about surgical techniques, and then you also need to talk about some minimally invasive endovascular techniques, which have really revolutionized the field. So even in the era of minimally invasive procedures, sometimes conservative measures have a significant role in the treatment of these patients. So a lot of patients will actually be better treated with conservative measures because they are pregnant, their symptoms are mild, they may not want surgical intervention. And so that's why conservative measures come into play. When we talk about weight loss, limb elevation, reduced periods of prolonged standing, those are all easy to prescribe for patients, but a lot of us are working, we have families, we're constantly on the move, so this becomes very challenging. Venoactive drugs such as Vasculera as well as sulodexide, horse chestnut seed extract, there have been many studies, especially in Europe, that have shown significant improvement. However, results are variable for many patients, and certainly more clinical studies need to be done in order for them to gain widespread acceptance in the US. Compression therapy is the standard for venous ulcers. And that's kind of the mainstay, especially with inelastic compression stockings. When you have C2 to C4 disease, graduated compression stockings are the standard. However, clinical results are dependent on the patient's compliance as well as in terms of their ability to wear them, especially in the heat or putting them on for elderly patients. There certainly are very significant variations in terms of compression. You could use bandages, boots, pneumatic compression devices. There's some new bandages out there called the K2 Ergo, which we are currently looking at, and those are promising. But again, it just depends on so much on compliance as well as whether the patients are willing to try to put them on, especially during the heat. So let's talk about some surgical techniques which have been described by Trendelenburg back in 1890. Charles Mayo, as well as William Keller and Stephen Babcock, described the first vein stripping back in 1905 to 1907. There certainly is significant results with that. Patients have done well with that, but there's a lot of complications from that. Patients develop nerve damage, significant anesthesia needs to be given. The return to work is prolonged. A lot of times, big surgical scars can occur from that as well. So obviously, it's not a perfect technique. Over the years, they have actually combined open surgical excisions with phlebectomies. And that's really where I've kind of combined surgical here, is to include different approaches to the surgical approach. Talk about ambulatory conservative hemodynamic management of varicose veins, which is CHIVA. This is popular in France. Surgical intervention is based upon the premise that varicose veins arise from secondary to venous drainage hierarchy. The tributaries drain into the truncal veins drain into the deep system. And by taking care of the veno-venous shunts, you are going to preserve the saphenous vein. This requires significant mapping and very detailed analysis of the anatomy. In the right hands, CHIVA has been shown to be just as effective as vein stripping or other technologies that are now used today. Again, this is much more popular in Europe. A variation of that is the ambulatory selective varices ablation, which is where selective phlebectomies are done over the superficial varices. And that also has gained widespread acceptance in Europe as well. One of the options for phlebectomies is the transilluminated power phlebectomy system by Trivex. This is where an incision is made into the area where the varicose veins are. There's a transilluminated catheter that's inserted in, and tumescent is instilled through that catheter. There's an illuminated light that also lights up and highlights the vein itself. There's a second incision, as you can see from the cartoon there, which has a trocar that I guess the best way to describe it is a directed liposuction, where the trocar morcellates the vein. After the vein is removed, then the transilluminator trocar winds up injecting tumescent anesthesia. This also has significant has some very good results. If you're interested in looking at it, there's a very good YouTube video online by Steve Elias that shows the technique. I just took a still shot of this, and this is his video right here. But essentially, patients get good results with it. However, there's quite a bit of complications from paresthesias because you're inserting this trocar, and the way it works is you're just dissecting through a lot of the soft tissue is subcutaneous fat. Patients wind up getting a lot of significant hematoma, but again, the results are good from a standpoint of varicosity removal. After talking about surgical techniques, actually, no, just going back, I just so that the fellows understand, I would consider surgical open techniques really for patients that have complicated venous aneurysms that are very close to the SFJ. But in general, nowadays, ligation or open excision just is very difficult to do with good results, but long-term results due to neovascularization. When you're dissecting in the groin there, you wind up leaving lots of tiny vascular cells, which wind up causing neovascularization. In addition, collateral venous drainage sometimes will also cause the results to fail after several years. So in general, consider open excision from a surgical standpoint for large venous aneurysms that are close to the SFJ. So when we talk about endovascular techniques, which have really revolutionized venous care, we have to talk about ultrasound guided foam sclerotherapy, as well as thermal techniques and non-thermal techniques. I kind of struggled to decide where I would put ultrasound guided foam sclerotherapy. And, obviously this is a non-thermal, non-tumescent technique, but clearly the CPT codes for this are put ultrasound guided foam sclerotherapy in a different category than the rest of the ablations. The goal here of sclerotherapy is to damage the endothelium and cause fibrosis and scarring of the vein wall, and eventually form a fibrous cord, which the body will absorb. Sclerotherapy in general is broken down into three broad categories: detergents, which are considered STS and polydocanol; osmotic solutions like hypertonic saline; chemical irritants like glycerin. Over the years, the selection of sclerosants really depends on how much experience that person has with it. Certainly, ultrasound guided foam sclerotherapy is very flexible, provides the operator to treat multiple different types of veins in terms of how superficial the veins are, how tortuous they are, how small and large they are. Depending on, you can adjust the percentage of concentration for the sclerosant. And then with the addition of the Tessari method, where we foam the solution, it provides greater potency as well as greater volume to the sclerosant, so making the procedure much more effective for larger veins. So these techniques obviously give us a great option in treating superficial as well as tortuous veins. When we talk about thermal ablation techniques, those are broken down into different heat techniques: radio frequency, laser, steam, microwave, and ultrasound. I will touch on all of them. So radio frequency ablation was first FDA approved in 1999. There are lots of randomized clinical studies. It's probably one of the most studied, if not the most studied after laser. Patients have done extremely well with significant less pain, less analgesic use compared to open or up surgery, faster return to work. The effectiveness at 1 to 2 years is excellent, somewhere between 90 to 99%, depending on which studies you read. Complication rates are very low, less than 1%, infection rates 0.2%. As long as you are not ablating in the right, if you are ablating in the right area, paresthesias below the knee should be minimal, if none. Durability for RF has been excellent at 5 years, 84% reflux free, and 73% absence of return of varicose veins. There are lots of options available now. Medtronic has obviously the catheter that we use, and then Venclose has another option, which has a segmental catheter. And then there's the RFS dark catheter, which is used for perforator veins. Thermal ablation was first FDA approved in 2002. There are various wavelengths. The lower the wavelength, the more target towards hemoglobin. The higher the wavelength, the more the target is the vein wall or water. The effectiveness of the laser itself is driven by a formula called the linear endovenous energy density, which is LEED. That's the ratio of power to the velocity of the fiber pullback. The faster you pull back, the larger the surface area, and obviously the lower the power density. This is the formula. So the higher the power density, the higher the rapid rise in temperature, and the higher the rapid rise in temperature causes a more significant damage to the wall as well as surrounding tissues. There are various tips to the laser fibers. I know that many of us are familiar with what we use, which is a bare tip fiber, but there are certainly jacketed fibers. The way that laser fibers work is just like in Star Wars or Star Trek. There's those phaser guns wind up shooting laser beams. Those laser light beams actually will perforate through everything, causing micro perforations and causing ecchymosis. That's why patients get more pain and discomfort after laser procedures. With the introduction of jacketed laser tips, that laser beam is more diffused. Back in 2008, BioLitech introduced a one-ring radial, which diffuses the laser beam into a radial ring, which spreads out the heat. If one ring was good, then they decided two rings would be better. They introduced the two-ring radial a few years later. And then just recently, last year, a company in Israel introduced the infinite ring radial, which has multiple rings through the tip of the catheter here, spreading the heat of the catheter. Spreading the heat of the fiber itself. Results from the infinite ring radial has been very good, very similar to RF. This is still not available in the US yet, but hopefully we'll have access to this at some point. Multiple studies have been shown that the higher the wavelength, the less pain and discomfort for patients. This is probably the most cited article that showed that. Hirokawa had a study where closure of GSVs with the 1470 nanometer laser using a radial two-ring fiber showed same closure rates as the 980 laser with significantly less pain and discomfort. We'll switch gears a little bit and switch to steam thermal ablation. This was first described in animals in 2006. Very similar obliteration rates to RF and laser at 94%. The steam works very similar to radio frequency. It just heats up the vein wall itself and doesn't perforate the vein. So therefore, much less ecchymosis, much less postoperative pain. Again, very homogeneous wall heating. The tip of the catheter, as you can see there, shows the steam which is injected through the catheter itself. The catheter is extremely thin, so it's very similar to a guide wire. You can actually thread it through and get it through tortuosities very easily. There's definitely some significant medical and economic advantages, right? The mode of heat is water, so there's no chemical side effects to it. The risk of DVT, if the water cools quick enough, what happens is the heat doesn't transfer into the deep system. There's really no risk for allergies, and because of the way that the steam is injected into it, it works just like RF, which is nice. And water obviously is very cheap, so the economic advantages are obvious. Here's some pictures of steam thermal ablation. This is a vein with the catheter inside the vein itself, and you can see the steam. We'll talk a little bit about microwave thermal ablation, which was introduced about over 10 years ago, but really has not gained a lot of traction. It's originally used for ablation of hepatocellular carcinoma as well as kidney resections. It was initially brought in because back when RF first was introduced, generators were extremely expensive. I remember when I first started, we were paying for the generators. They were right around $20,000. And so the impetus was, hey, look, let's find a way to reduce that pricing. But as time has gone on and Medtronic has become more competitive, they now don't charge for the generators. They really just charge for the use of the catheters. And so a lot of times now, the impetus for trying to get microwave thermal ablation to the market has decreased significantly. It's nice because it does not require any contact with the vein wall to ablate the vein. The risk for skin burns is much less because the heat doesn't get as high as radio frequency or laser. It only gets up to about 80 degrees Celsius. And because there is no laser, there's no need for goggles. So it's a little bit easier on clinical staff. Some exciting stuff that's on the market or that's coming on the horizon is ultrasound technology. So this is in the early stages. It's a non-invasive therapeutic technique. It's new. There's no need for catheters. What happens is an ultrasound machine that you can see on the picture there. That is the actual device. The ultrasound focuses a beam of sound waves onto the target vein. I'll show you a picture of that in terms of how that works. But the beauty here is there's no insertion of any catheters. That you can repeat the procedure if needed. It doesn't cause significant damage to surrounding tissues because the ultrasound is focused. So there's a large clinical trial, and I'm sure this I had looked this up a few months back, but I know that the trial was just recently published, and the results have been good. This has been actually it is not currently FDA approved, but it does have the CE mark in Europe under the Sonovane system, and pretty promising, pretty exciting stuff. Here's a picture of the ultrasound in action here. So the first picture is just the vein itself with some local anesthesia in it. You can see how the beams of light, where the arrow points, that's where the sound waves, I should say, not beams of light, but the sound waves converge, and that's where the focus of heat is. So near the surface, the sound waves are more spread out, but as they focus down into the target vein, that heat damages the vein wall. And then on the last picture to the right there, you see the obliteration of the vein itself. Here's a picture of pre and post, again, occlusion, and showing effectiveness of ultrasound. So let's talk a little bit about endovascular non-thermal techniques. So obviously, we're very familiar with the fact that there's no heat involved. That means there's no tumescent needed. There's really low to no risk of nerve damage, much less pain involved. Obviously, if you're not doing multiple sticks for tumescent, then much less sticks for the patient. Very comparable closure rates, if not better, especially with venous seal. All have their risk and benefits, and we'll talk a little bit about them now. So Varithena is the commercial foam. This is indicated for all veins that involve the great softness veins, the accessory veins, visible varicoses, the varicose of the GSV above and below the knee. It does not have the indication for the small saphenous vein. And also, if you look closely at the LCD, it does not have the indication for non-saphenous veins. So just if you guys are treating non-saphenous veins, the Varithena does not have that indication. It is extremely effective, especially if done properly. And we'll talk a little bit about some of the techniques. So some of these pictures are from Varithena itself, but Nick Morrison, if he's on the call, will tell you that the quality of the foam is the most important thing here, and you can see that the physician compounded foam, which has much more non-uniform bubbles, as well as not much less dense. Varithena has that that consistency of shaving cream and the effect on the vein wall, which I'll talk about in the next slide. That's really where the importance of this, the importance of commercial foam is. The consistency displaces the blood itself, which causes much more contact with the vein wall. The other part of Varithena that's important to realize is that the reason why ultrasound-guided foam sclerotherapy has a risk to patients from a standpoint of neurovascular events is because nitrogen in the air represents approximately 70%. And nitrogen does not dissolve very well in the bloodstream, whereas carbon dioxide and oxygen dissolve extremely well. Varithena itself has the device actually mixes oxygen and carbon dioxide with the polydocanol, and has a very, very low amount of nitrogen. And that's the beauty behind Varithena in terms of safety. So here's a picture of the Varithena displacing blood. Again, the key to this is the safety aspect, but then the density of the foam itself, which helps with the effectiveness, right? The safety is regarding the oxygen and carbon dioxide solubility and the fact that nitrogen bubbles don't go to the brain. The effectiveness is really based upon the consistency and density of the foam itself. And here, what the first picture you see is the Varithena displacing the blood, effectively filling the lumen. That causes significant spasm in the vein wall and putting more contact with the Varithena bubbles with the endothelium, damaging it. The way that these procedures should be done is to map out the vein very, very in detail to make sure that you're seeing all the perforators, and then tilting the patient back fully. I personally feel that access in the vein with a patient in Trendelenburg and getting all the blood out of there is extremely important. Compressing the vein itself is also very important, and then using the right needle or introducer is key. Many of us, if we're doing it by a butterfly with a very small lumen, you're actually disrupting these bubbles, and you're actually not getting the effect of the displacement of the blood. You really need a nice column of Varithena with enough solution to displace the blood, and that's really the key to this to the procedure itself. We'll talk a little bit about mechanical chemical ablation. Many of you guys are familiar with Claravane, so this was introduced just a little bit over 7 years ago. It is a combination of chemical ablation as well as mechanical ablation. Then the metal tip on the end of the catheter itself damages the endothelium, and at the same time, injection of a sclerosant, whether STS or polydocanol, further denudes the endothelium and causes the vein to close. The mechanical whip also spasms the vein wall as well, and also agitates the solution, thus increasing its effectiveness. Studies have shown this to be very effective. I will tell you that this is probably very operator dependent, but the Maradona trials study back several years ago showed just as or very similar occlusion rates to radio frequency. However, the patients wound up having a little bit more discoloration and staining due to the sclerosant itself. Interesting to note, VCSS scores for Claravane improved much more quickly than RF. However, at 1 year and 2 years, the data for patients was very similar, but clearly return to activity and much less pain was noted with Claravane. We have trialed Claravane in our practice, and we have found that closure rates were variable, and opening of the vein was noted. It's interesting to note that there have been several studies out there that have shown the same studies that we have noted, where the vein did reopen. However, when it does reopen in certain segments or in different segments which were not clinically significant. So although we also noted the veins to be open at 6 months, 1 year, we didn't look at the clinical significance of that. And when people did look at that, it did not show a significant difference in terms of how patients felt, which is interesting. And finally, we'll talk about VenaSeal, which is my favorite procedure. This is cyanoacrylate, which is the glue. Nice thing about the glue is that it is antimicrobial, so much less risk for infections. People sometimes will say, well, this is an implant that's in my body, and I don't know what it's going to do to me 50 years down the road. The glue has been used in medicine for over 60 years. In the ER, we use it for skin closures. In surgery, they use it for AV malformation repairs. For ophthalmology, they use it for retinal detachments. So it's been used, and there's never been a study that has shown it to be carcinogenic. It is extremely safe. A lot of times people will say that it is considered an implant, and yes, it is an implant. However, in our experience, we have noted that the glue does degrade over several years, so eventually it does break down. It's nice because it is very, very durable. 5-year data now has shown that it's probably just a little bit better in terms of durability than radiofrequency and laser. Nice because there is no requirement for stockings after use. Patients wind up getting one stick where the insertion site is for the catheter, but other than that, the rest of the procedure is done without any further injections. Here's a picture of the system itself. You access the GSV, thread the catheter up to about 5 centimeters from the SFJ, compress approximately from the junction. Important to note that the first pullback, I think people always get confused here, but the first pullback is 1 centimeter and then 3 centimeters, and then you compress for 3 minutes. Everything else is 3 centimeters, and then you just repeat the process all the way down. Another thing I always tell people is that the amount of glue is extremely small. So if you notice here, it's 0.1 cc. So an entire GSV can probably be treated with about 2 to 3 cc's of glue itself. Here's a picture of the VenaSeal catheter. You can see that the glue is being injected. The tip of the catheter is shown here, and it has a stellate pattern or a star pattern, so you can identify it, and that way you can compress just proximal to it. So in conclusion, there are lots of new and exciting technologies on the horizon. Clearly, there's a lot of excitement over VenaSeal. It's important for us to be familiar with all of them. It's also important for us to choose a mixture of everything in terms of treating patients, and that way they get the best results.
All right, excellent. Thank you, Ken. Does anybody have any questions for Dr. Nguyen regarding some of these newer technologies?
Dr. Nguyen.
Yes, sir.
Hey, this is Sagar. Regarding the steam technology, did we at any point at CVR ever use that steam technology that you were speaking of?
So the steam is not not FDA approved as of right now, and none of the insurance companies are approving it, Sagar. So it still requires more. I think it's definitely exciting in technology because just for the reasons already discussed. But yeah, as of right now, it's not approved for use either by insurance companies or by the FDA yet. So
okay.
Yeah. In addition, I just want to point out for everybody that Dr. Nguyen mentioned the Trivex system. One of the downsides to the Trivex system is that it requires general anesthesia, and it's currently only being used in inpatient settings. So that's one of the other issues. The other issue is that it causes an enormous amount of bruising and in some cases bleeding, which is why it really never kind of took off as a major technology as well. All right, so I just wanted to remind everybody, for those of you who may have joined a little bit late, we are now able to offer CMEs for participating in the meeting. If you go to the chat box, you'll see a link. If you click on that link, there will be a survey that you have to fill out. If you fill out that survey, you will then, at the end of the year, receive credit and CMEs for this. For those of you who want to watch that later, Stephanie will send out a copy of this lecture from Dr. Nguyen today. It'll take you to a YouTube page, and at the bottom of the page in the comments section will be this link again, where you can fill out the survey and receive credits for it. So thank you, Ken. Good lecture as always. And everybody have a great weekend.
Thanks, guys.